Hello, my name is Dr. De Sosa. I am a PGY1 resident in the Internal Medicine Department at Florida Atlantic University in Boca Raton, Florida. Today, I will be presenting a unique case on the successful management of COVID-19 mediated extensive bilateral pulmonary embolisms complicated by right ventricular strain and DKA. This work was also contributed by Dr. Sinowi and Dr. Sarif Saret. Throughout this presentation, you will find a QR code on the left-hand side. Please feel free to access it at any point to view the full report pertaining to this case. COVID-19 can precipitate DKA in patients with or without pre-existing diabetes. Similarly, the link between COVID-19 and thromboembolic complications has been well established. Currently, no data addresses the management of patients with both extensive thromboembolic complications and DKA. For this reason, we report a unique case on the successful clinical management of a patient who presented with DKA and bilateral pulmonary embolisms with right ventricular strain simultaneously. He is a 42-year-old male with a medical history significant for unspecified psychiatric disorder and recently diagnosed non-insulin-dependent type 2 diabetes mellitus, who presented to the emergency department complaining of shortness of breath associated with subjective weakness, lethargy, and worsening non-productive cough of 2 weeks duration. On review of systems, he denied any anosmia, ageusia, or changes in bowel habits. On arrival, the patient was hypoxic with oxygen saturations of 86 to 88% of room air, tachycardic with a heart rate of 120, and tachypneic with respiratory rates of 40 to 50. He was otherwise afebrile and normotensive. In-house PCR test was positive for COVID-19. E-Plex panel for other possible viral respiratory infections was negative. CBC was significant for lymphopenic leukocytosis with neutrophilic predominance. ABU was significant for compensated metabolic acidosis. BNP and urinalysis were consistent with an iron-gum metabolic acidosis in the setting of DKA and lactic acidosis. Hemoglobin A1C was markedly elevated. The elevated troponin was concerning for acute myocardial injury, and EKG showed findings consistent with right ventricular strain. Additionally, the patient was found to have a low C-peptide and negative autoantibodies to islet cell 2 and glutamic acid decarboxylase antibodies were negative as well. Chest x-rays show patchy infiltrates in the left, mid, and lower lobes, consistent with viral pneumonia. CTA was obtained and showed extensive bilateral pulmonary embolisms, evidence of right ventricular strain, multifocal bilateral ground glass opacities in the peripheral distribution, and areas of wedge-like consolidation concerning for evolving infarction. Transthoracic echocardiogram was significant for ventricular strain, although not shown in this presentation. Bilateral venous duplex ultrasound was negative for DVT, also not shown in this presentation. The patient's calculated pulmonary embolism severity index, or PESI score, was elevated at 112, and simplified PESI score was 2, which placed him at a class 4 30-day mortality risk. Based on these findings, his bilateral pulmonary embolisms were graded as intermediate high risk. In the emergency department, standard DKA management was initiated, with aggressive IV fluid resuscitation and insulin drip. He was started on empiric treatment for community-acquired pneumonia with a 5-day course of ceftriaxone and azithromycin due to a high index of suspicion of superimposed bacterial pneumonia in lieu of his unilateral chest X-ray findings. The patient was then transferred to the ICU, or intensive care unit, for management of acute hypoxic respiratory failure and was placed on 100% fraction of inspired oxygen by high-flow nasal cannula. At this point, our team was confronted with an important clinical conundrum, as management of DKA with aggressive fluid resuscitation carries the physiologic potential of exacerbating ventricular interdependence in patients who also suffer from COVID-19 mediated thromboembolic complications. In the ICU, the main inside fluid rate was decreased to 75 cc's per hour due to risk of ventricular interdependence in the setting of right ventricular strain, and the patient's DKA was managed via insulin drip. On hospital day 2, IV fluids were discontinued following closure of an iron gap twice. Catheter-directed thrombolysis was unsuccessfully attempted due to increased agitation on behalf of the patient. The patient then received systemic TPA infusion for thrombolysis of bilateral PEs, with significant improvement in respiratory status and resolution of his tachycardia. The patient was transitioned to full dose enoxaparin post-thrombolysis, with eventual initiation of direct oral anticoagulation with apixaban prior to discharge. To our knowledge, only one other case report exists addressing the clinical management of a patient afflicted by both of these COVID-19 mediated complications during the same hospitalization. The other case report described the successful management of a 46-year-old unvaccinated female who suffered from DKA and multiple subsegmental pulmonary emboli despite receiving prophylactic anticoagulation. However, the onset of her complications occurred in a successive fashion, while our patient presented with both COVID-related complications simultaneously. Although the exact mechanism of DKA in COVID-19 is not fully understood, it is believed that the viral entry into pancreatic islet cells may cause direct beta cell injury and downregulation of ACE2, leading to low pancreatic insulin release. Interestingly, this pattern of injury was supported by our case report, as our patient had low C-peptide levels but normal autoantibodies to islet cells and glutamic acid decarboxylase. COVID causes thromboembolism via viral attachment to ACE2 receptors in pulmonary epithelium and endothelium, which leads to pro-inflammatory cytokine activation. Acute right ventricular failure with resulting low systemic output is the leading cause of death in patients with intermediate to high risk PEs. Current guidelines for the management of acute pulmonary embolism recommend volume optimization, but with caution in volume loading, as over-distending the right ventricle can worsen ventricular interdependence and reduce the cardiac output. In our case, the patient had already received volume loading due to his presenting of DKA. Upon further assessment of his volume status, additional fluid challenge could have resulted in worsening of right ventricular function. Therefore, the decision to run maintenance IV fluids at a lower rate from the recommended based on his body weight was made. This case report is not free of limitations. Our patient had a history of uncontrolled type 2 diabetes mellitus with a markedly elevated hemoglobin A1C and emission, in conjunction with a suspected superimposed bacterial pneumonia infection. However, the incidence of DKA in adults with type 2 diabetes is less than 2 cases in 1,000 patient years, making the COVID-19 mediated DKA the likely culprit. It is also unclear if the patient's psychiatric condition played any role in the development of DKA. We knew the patient was on a long injectable antipsychotic, but we never unearthed if it was a first or second generation drug. And second generation antipsychotics have been associated with an increased incidence of DKA. In conclusion, the findings of this case suggest that running IV maintenance fluids at a lower rate of the recommended based on body weight in DKA may be the key in successful recovery of COVID-19 patients also suffering from concomitant and extensive thromboembolisms with right ventricular strain. We recommend that in patients presenting with these two COVID-19 related complications simultaneously, treatment and progression prevention of their thromboembolic complications should take precedence over a goal-directed DKA management. These are my references. Thank you very much.